So it's a pleasure to be here, and what I'll try and do is give you an update on the guidelines that were released by the American College of Cardiology and American Heart Association that grew out of work that was originally being done by the NHLBI to update the NCEP guidelines, show you some of the scientific evidence that really supports the use of statin therapy and why the guidelines really evolved and shifted from their approach of just looking at LDL towards actual risk reduction and a little bit of practical implications of these guidelines, as well as a little bit of the controversy that they've indeed engendered. So here are my disclosures related to this presentation, so please keep them in mind. So the thing fundamentally that we should be focusing in on is the tremendous burden due to atherosclerotic vascular disease. And the vast majority of these individuals having these events, they could have been prevented with better implementation of preventative therapies. And both individuals that thought they were entirely healthy and didn't realize they were at risk for an atherosclerotic event, as well as those that knew they had risk factors but weren't adequately controlling them, or as well as those with underlying disease that hadn't taken full steps to prevent recurrent events. So we've got 1.4 million myocardial infarctions a year, 800,000 strokes every 30 seconds, somebody dying due to cardiovascular disease. And although we're spending billions and billions on cardiac caths and revascularization and stents, only to have patients still go on and have events, and this tremendous economic burden that the AHA estimates as much as $315 billion occurring each year. Again, the vast majority of these events could have been prevented. So we've known for literally decades about this relationship between LDL cholesterol, the bad cholesterol, and the risk of atherosclerotic events. And although guidelines previously used a variety of cut points, I think you can see pretty clearly this is a linear relationship. So any arbitrary divide of, oh, get the LDL down below 100, you realize, is there a real difference in risk between 101 and 99? Have you accomplished anything just crossing that barrier? So it's been this continuum of risk. But most importantly, look at what utilizing these LDL cut points did with regards to identifying who was at risk and who would benefit from treatment. Because when we actually look, what percentage people in the United States that are going to go on to have an acute myocardial infarction have an LDL that's below 100? It was 50%. So to say, hey, you're below 100, you don't need to worry about this, left half the individuals having acute myocardial infarctions completely uncovered. You pick less than 130, that was 77% of those ultimately going on to have an MI that would be missed. And you pick less than 160, that was 92% of the individuals having acute myocardial infarction completely missed. So it begins to show you that the guidelines that existed really did not make a lot of sense and left a large number of individuals still at risk for events kind of uncovered when the focus was just on LDL. Okay, well, do we know that lowering LDL with therapy can prevent events? Well, when we looked at trials that used diet to try and lower LDL, it really was not very convincing, in part because it was hard to get adherence, in part even when there was adherence, you got very little LDL reduction. And so it wasn't until the HMG-CoA reductase inhibitors came around to where you could get very large, 30, 40, 50% reductions in LDL, that we had a series of trials that demonstrated that applying statin therapy versus control on a background of therapeutic lifestyle change, diets, and exercise, that you could lower the risk of first events, second events, third events, fourth events, however you want to cut this. So in our primary prevention populations, high-risk mixed populations, some with documented disease, some without, and those with established disease, that you could markedly lower the risk of having fatal and non-fatal cardiovascular events. And rarely do you see this in clinical medicine, where across trials, pretty uniform and very consistent results with reductions between about 27 and 38% in major cardiovascular events occurring. One of the first compelling trials because it answered the question of, are you just shifting from having a cardiovascular event to going on to ultimately have something else happen to you, such that survival was not extended. This trial in 4,444 individuals, known CAD, randomized to 20 to 40 milligrams of simvastatin versus placebo on top of background diet and other therapies they may have been on. There was a reduction in hospitalizations, need for revascularization, major coronary events, coronary mortality, but importantly, the first demonstration, individuals actually live longer with statin therapy, a 30% reduction in all-cause mortality and with a highly statistically significant p-value, and with benefits across all of the patients studied. So when we put these trials together, so this is a meta-analysis of 90,000 individuals in 14 different randomized clinical trials, all placebo-controlled. At the time of this analysis, over 400,000 patient years of follow-up, meaning this is the best studied therapy ever in history as far as patient years of follow-up in randomized placebo-controlled trials. And what was shown was a 23% reduction in major cardiac events, 20% reduction in CHD mortality, 22% reduction in ischemic stroke. Importantly, the benefits entirely proportion to the LDL reduction achieved, had absolutely nothing to do with what baseline LDL cholesterol the patient started off with. There were benefits no matter how old you were or how young you were, whether you were male or female, regardless of your race, ethnicity, or other comorbid conditions. Importantly, the benefits in relative terms were absolutely identical in those that were apparently healthy and had never had a previous coronary event to those with established cardiovascular disease. So primary and secondary prevention, absolutely similar reductions. And importantly, on the safety end, no increase in cancers, any individual cancers or cancers as a whole, or cancer mortality. No difference in any other major comorbid disease, and no difference in non-cardiovascular death. So you can't see it here, but on this slide, all of these clinically relevant subgroups, regardless of what LDL cholesterol you started off, no matter what your HDL cholesterol was, no matter what your triglycerides were, no matter what your blood pressure was, no matter what your body mass index was, no matter what your baseline level of exercise was, no matter what your diet was, being randomized to a statin versus placebo, there was a significant reduction in major cardiovascular events, no heterogeneity seen. Okay, so this is really shocking, right? You're telling me a person who's already at goal that has an LDL below 100 would get the same benefit if somebody with a bad cholesterol level above 160 sky high? But that's what the data actually shows. So those starting off with LDLs below 100 randomized to statin versus placebo, you can see a very similar relative risk reduction here to those between 100 and 130 and greater than 130. No heterogeneity at all, similar 24% risk reduction. In fact, there were about 1,000 patients in this study that started off with LDLs below 80, and they still benefited from statin treatment, and it was safe and well tolerated. So then we had a series of studies that were done looking at, well, is it okay to just be on any dose of any statin, or would more intensive statin therapy, getting greater LDL reductions, give us even greater benefits? So this is one of the trials. Patients had ACS randomized to 40 of pravastatin versus 80 of atorvastatin, one of our most potent statins. You got some additional LDL reduction, and you got a nice additional 16% reduction in risk. Importantly, equally well tolerated, as many patients stopped 80 of atorvastatin as stopped 40 of pravastatin. Here, yes. So what this shows us, so of those that were on standard therapies plus got interventions and everything else and 40 pravastatin, there was a 26.3% event risk. Those on 80 of atorvastatin, it was reduced to 22.4%. So we're talking there about a 4% absolute risk reduction in events, 16% relative risk reduction, highly significant. But here's the thing to know. The coronary intervention itself in non-ST segment elevation MI lowers event risk by about 2%. So what a physician can do with their prescription pen here is stronger and has a bigger impact on the patient than what the interventional cardiologist is doing in the $20,000 procedure putting in the coronary stent in somebody having a non-STEMI.
And doesn't it also say that which agent you choose matters?
Yes, so the intensivity of the statin matters. Here's another trial. These are stable CAD patients where they randomize them to 10 of atorvastatin versus 80 of atorvastatin. And, you know, the on-treatment LDL in the 10 milligram group was, you know, about 198. And in the 80 of atorvastatin group, it was around 77. And what we see here is additional risk reduction. You can see the numbers needed to treat, but about a 22% additional relative risk reduction. So putting all the trials together of more versus less intensive statin therapy, and this is what leads to the rationale why the guidelines get pretty explicit for those with documented vascular disease, why we should be using high intensity statin therapy, is you can see pretty convincingly on this slide a 16% additional reduction in events beyond the moderate intensity statin, and, you know, very impressive number of zeros in the p-value. So this gives us scientific data. That's on the efficacy side. On the safety and tolerability side, we did not see major differences in withdrawal or serious side effects regarding the high versus less intensive statin therapy, with the caveats, of course, these were patients in trials and the investigators would not be putting people on combination with fibrates or cyclosporin. They would be paying attention to those type of things. Okay, beyond the benefits of preventing time to first event, here's an analysis looking at recurrent events. So statin therapy, more intensive versus less intensive, this is from the TNT trial. You had the nice reduction, about 20% in first events, but look about second events, another 21% reduction. Third events reduced, fourth events reduced, a 29% reduction in the fifth event in these patients. This is a progressive disease. More intensive therapy offers benefit, not just lengthening the time to your first event, but preventing it as well as preventing subsequent events in these patients. Okay, you'd say, yeah, but there's a lot of concern about side effects and tolerability, and if you put people on these high-dose statins, you're going to be driving these LDLs down to scary levels, 40 to 60, less than 40. Clearly, that cannot be safe. But here's the actual data in these trials. So you're looking at the on-treatment LDL, what LDL that patient got down to and stayed at for the next 4 to 5 years as they were followed in the trials. And so this is looking at any reported muscle abnormality, myositis or myalgias, having elevation in muscle enzymes, the CK, having overt rhabdomyolysis, and remember we're following thousands of patients here, you don't see a single event occurring, or increase in liver function tests. And what you can see, no matter what on-treatment LDL was, these agents were as well tolerated as placebo, sugar pill, and no difference among those even getting down to very low LDL cholesterol levels. So by having hundreds of thousands of patient years of follow-up, we're able to answer this issue regard to safety. Okay, what about our patients with diabetes? We tell them how critically important glycemic control is, diet and exercise. Well, there was a great study looking at 8 years of diet, exercise, and weight loss in patients with type 2 diabetes called Look Ahead. It was actually successful in helping patients lose weight and adhere to diet and better control their blood sugar, and there was absolutely no reduction in cardiovascular events, not a one. We have all these trials of glycemic control that have unfortunately not lowered the event risk in our patients with type 2 diabetes. But here's a trial that gave patients with type 2 diabetes whose lipid levels were pretty normal at baseline 10 of atorvastatin versus placebo. Trial stopped early because there was a 37% reduction in first major cardiovascular events. So we can see a large benefit, and this was not just cardiac events, but also stroke events. Here's a trial in patients with hypertension. So long as their cholesterol was not too high, they were randomized to 10 mg atorvastatin versus placebo after their blood pressure had already gotten to goal. So these are well-controlled hypertensives whose blood pressure is now below 140/90, getting a statin versus placebo. Their first major cardiovascular event, non-fatal MI, fatal CHD, reduced 36%. And look at how early the benefit was seen here. These curves are diverging not in years, not in months, in weeks. We are already seeing benefit for patients being treated. And the benefits entirely independent of what LDL they started off with. So here's a study, TEXCAPS, AFCAPS. These were healthy Air Force employees. So we're talking individuals in pretty darn good shape, and they had no known cardiovascular disease. They could have some risk factors and be included in this trial, but most did not and were apparently healthy. They were randomized to statin versus placebo, and you can see the risk reduction in first major cardiovascular events reduced 34% in men, 54% in women. You hear the stuff that you can read in Time Magazine and New York Times about statins not protecting women from their first cardiovascular events. This is the actual data. It is completely bogus to say that there is not overwhelming evidence of protection for women and men, older and younger patients, smokers and non-smokers, hypertensive, normaltensive, diabetics, non-diabetics. So here's some interesting findings. We're going to compare those who were on statins versus placebo and look at what impact it has. Now you know how tremendously detrimental smoking is on the atherosclerotic risk. But look at the impact in the smokers in this study. So of course, those smokers that were on placebo had this super high cardiac event risk. And those smokers that, the non-smokers had a much lower risk, obviously, compared to the smokers. But look at the smokers who got lovastatin therapy, a statin. What was their risk? It was actually below the non-smokers on placebo. You completely negated the atherosclerotic risk of smoking with a once daily statin. Now, nobody is ever going to say to a patient, oh, just keep smoking and just take the statin. And clearly, the non-smokers on the statin did the absolute best. But think about this, that you could negate over this period the risk of smoking with statin therapy, again illustrating how incredibly potent LDL lowering with statin is for negating cardiovascular risk. Older individuals, obviously at higher risk, put on a statin, their cardiovascular age looks a whole lot younger. Certainly that they were matching, those older patients on lovastatin look a lot like the younger patients on placebo. Here, men obviously at higher risk at an earlier age for atherosclerotic events. Their risks on a statin seem to get down to the women on placebo and even those with a family history. So we can negate some pretty potent cardiovascular risk factors with concomitant statin use. Okay, so here's the Jupiter trial. This took patients that the guidelines said, the older guidelines, shouldn't be treated. Their LDL was already below 130. They didn't have any known atherosclerosis. They were fine on diet and exercise alone. And randomized them to a pretty potent statin, 20 of rosuvastatin versus placebo. And here were the results. You see a 44% reduction in first major cardiovascular event. They were planning to run this study for a really long time, but the results were so striking they stopped it early. Now you can see when you get down to lower risk patients, why the relative risk reductions are very large. In absolute terms, we're getting to smaller absolute risk reduction. The number needed to treat over 5 years to prevent one event is 25, so you will be treating 25 individuals to prevent that one major event. But in those individuals, we're cutting their event risk in half. And although you see about 5 zeros followed by 1 here, this trial was so large there are actually 13 zeros followed by 1. There's less than a 1 in multiple trillion chance that this is not a true effect. Okay, so now let's look at all of the different events here. And this slide shows it, but what I'll have you most focus on beyond the reductions in stroke and any which way you want to cut cardiovascular events, all-cause mortality in these apparently healthy individuals was reduced. So further evidence in both men and women, those that didn't qualify for treatment guidelines, apparently healthy, you saw this very substantial reduction in events. And now when we look at, okay, who benefited more or less here, men and women, equal benefit, right? You see no difference in that relative risk reduction. If anything, maybe slightly greater benefit for women. Older and younger patients, smoker and non-smoker, regardless of race, ethnicity, underlying hypertension, body mass index, baseline lipid levels, family history of CHD or not, metabolic syndrome or not, Framingham risk score being very low risk, still benefited, a little higher risk, still benefited, no ATP risk factor, still benefited, one or more risk factor. So across the board here, high, intermediate or low risk individuals deriving benefit. Okay, that's all on the efficacy side. Let's go back to safety. Here's 17,000 patients randomized to statin versus placebo. So were there some events reported on this statin? There absolutely were, but they were at the same rate on placebo. So you can see when you tell somebody that you're starting this medication that may lower your cholesterol, but it can have some of these side effects, you will have up to 16% of individuals report that they are in fact having muscle weakness from this pill that you gave them when that pill is sugar pill. So that is critically important, because if you know it's a statin that you're giving them, you're going to say, oh, it's due to the statin. When you're the blinded investigator, say, I'm not sure, is this placebo, is this drug? And when we count this up, we see absolutely no difference here. Myopathy, 10 versus 9. So, and we're talking a rate here of 0.1% versus 0.1%. You can see for things like cancer, liver function test, 0.2% with statin, 0.3% with statin, 0.2% with placebo. So very unusual. The one thing that was different between statin and placebo was there were slightly more new onset or newly diagnosed diabetes cases that occurred. You can see a very subtle difference with regards to the glucose levels, 98 in both groups, hemoglobin A1C just a 0.1% difference, but there was a slight excess in this study, so 0.6% for new onset diabetes. Almost all were ones on the edge of diabetes and being tipped over, but that is the one thing we have seen with statins compared to placebo that occurs with the greater incidence there. So there's been a lot of discussion about this. Clearly the benefits of statin therapy outweigh the risk. Even in those that developed new onset diabetes, they came out ahead because they had a large reduction in major cardiovascular events. But you do need to disclose that obviously to patients. There will be a slight excess in diabetes events. So you can see the data here. Roughly it works out to be something about, a number needed to harm about 1 out of 450. With the NNTs for benefits, you saw about 1 in 25. Okay, so here's a meta-analysis that gets at to just primary prevention trials. Can you tell individuals starting a statin will lower their risk of all-cause mortality? The answer, according to this meta-analysis published in JAMA, was in fact yes. So a reduction in all-cause mortality for primary prevention. You can see for any adverse event, absolutely identical to placebo. The one exception, new onset type 2 diabetes. And this article offers the relative risk reduction, the NNTs as well. So as we look at this across our risk groups, we are seeing benefits with statins, and the benefits are major coronary events, stroke reduction, and need for revascularization procedures. Now we know not every patient, even in trials, are adherent to the medication or necessarily responsive. So here's an analysis from Jupiter where they compared those that were on study drug and got their LDL down below 50 to see how they did compared to those on placebo. And what this showed then in these otherwise healthy men and women age 50 above for men and 60 and above for women, first major cardiovascular events were reduced by 65%, MI, stroke, CV death 74%, and all-cause mortality reduced by 46%. So we can see a potent statin getting that LDL down very low, this remarkable benefit. And importantly, rates of adverse events in cancer similar among rosuvastatin and placebo. The one exception, higher risk of new onset diabetes. So in fact, what they did do is say that we will use the potent statin. And the reason for that, I'll give you a little rationale, because if you didn't get below 50, adding in another agent to try and get you down there that's non-statin therapy, we haven't yet shown that. And so that's why the maximize our therapy to get maximal risk reduction, but going beyond that just to lower LDL, we've got to prove that works first. So that's the rationale. But the guidelines tell us by giving a potent statin like 20 of rosuvastatin or 80 of atorvastatin, you're often going to get the majority of patients down to that type of level. So in all of these circumstances, cardiovascular risk has been reduced with statins. So, I mean, isn't this the ultimate in personalized therapy? If you're a person, you seem to benefit here. I mean, so it's a little facetious, but on the other hand, this idea of targeted therapy, or I know you're the one that will benefit from a statin and I know you're the one that won't, we haven't been very good at. We haven't identified a subgroup that does not seem to have benefits that outweigh the risks in that regard. And so that is why the foundation then for the guidelines that are going to talk about intensive statin therapy for our high-risk patients and settle for moderate intensive statins for lower risk patients, a lot of it is based then on this concept that the more potent the statin, the greater the relative risk reduction that we get. And so to get that 50% reduction in event risk and 50% reduction in LDL, then the guidelines come out in support of atorvastatin 40 or 80, rosuvastatin 20 or 40. And you can see what qualifies as moderate intensive statin. And low intensive statin in general is not recommended unless that is all that can be tolerated by that patient. Okay. So, if we look at the old guidelines, they had this sort of, in the very low risk patient, intermediate risk, and high risk, we'd on the low risk patients just recommend diet and exercise. Intermediate risk, you could consider drug therapy. Higher risk, that's who you treat. You realize this was all completely absurd because you'd go, oh, okay, it'd be 80 people to benefit, so I don't want to treat them. But you could have taken a statin and cut it into quarters and suddenly the NNT is down to 20. And so it really made very little sense to sort of have this gradation of risk of who you were actually going to treat. Now, this issue of why not, still target lipid levels and just move them down low below 50 or some other target. Part of the challenges we've seen in these trials that have looked adding a second therapy onto the statin, none of them have actually worked to engender benefit, whether the goal was further LDL reduction or whether it was raising HDL or lowering triglycerides. So the ACCORD trial added a fibrate to statins, offered no benefit. AIM-HIGH added niacin to statin, no benefit, and there was actually a safety issue, more strokes. Heart protection study 2 with niacin in a formulation with another drug to block flushing. There were safety issues and didn't reduce events. Ezetimibe in the SHARP study did show benefit, but the control was placebo, not another statin. Illuminate, which was with the CETP inhibitor, it raised HDL, but it killed people. And the Dow outcome study raised HDL by 30 to 40%. If you followed the epidemiology, you would have thought there'd be a 90% reduction in events with the CETP inhibitor. There was absolutely no benefit. Now, we do have some trials going on for further LDL reduction. Ezetimibe added on to high-dose statin therapy and improve it. And there are trials going on the PCSK9 monoclonal antibodies. If they end up showing benefit, then we'll say, hey, it's back to LDL and more intensive LDL reduction, but we don't yet have that data. Okay, So this kind of takes us to the clinical implications of basically using baseline LDL to decide who to treat was never evidence-based and leads you to making the wrong type of decision. Treating the LDL to a goal misses the mark because you recognize some of the absurdity where the benefit's directly in proportion to your percent LDL reduction of going from an LDL of 101 to 99. You have accomplished nothing. Yes, they're quoted goal, but you have not lowered the risk at all. Somebody starting off at an LDL 100, lowering it by half with a potent statin, you've cut their risk in half. And even if your LDL started at 70 and cutting that down in half, you've lowered the risk by half. And so across these cardiovascular risk groups, the benefits of statin therapy outweighs the risk. And with the availability of generic statins, it removes this whole cost control, cost containment rationale when you can get the therapy for $40 a year and thus can move into intermediate and low risk patients and still be very cost effective. So that's the rapid background for the guidelines that were released. Here's the writing group. A lot of work over 5 years went into formulating these guidelines. And so the general principles, of course, this is not saying just start statin. All adults should be adhering to a healthy lifestyle and all of the things that it means. And there was a full guideline put out around what is behind a healthy lifestyle, diet and exercise, and that is the background and basis and backbone of therapy. But statins are recommended in those adults who have been demonstrated to be benefit, and there are 4 groups that are defined. Those with documented disease, those with sky-high LDLs, regardless of their age, those with diabetes, and those where, on the basis of their risk factors, their estimated 10-year risk is 7.5% or higher, and consider, even if it's 5% or higher, that they should treat. So here's the little algorithm that was put forth, and it's again trying to identify those primary and secondary prevention patients that would benefit. For those with documented disease, intensive statin therapy. Those with sky-high LDLs, intensive statin therapy. For those with diabetes, the medium intensive statin therapy is thought to be reasonable to utilize, though it's still an option to use high-intensity statin, and also in the primary prevention population. Okay, so the benefit group 1, these are all the patients with documented vascular disease, and what is recommended is high-intensity statin therapy for those that are between, less than age of 75. Above 75, they were less represented in the trials. It's certainly reasonable to treat those individuals, but you want to have a discussion with the patient regarding their goals. If the patient can't tolerate high-intensity statin, moderate-intensity statin is a reasonable use in those that can tolerate high-intensity statin. Next group, the relatively rare patients with LDLs above 190. Most have familial hypercholesterolemia. Get them on a high-intensity statin. Those with type 1 or type 2 diabetes between 40 and 75, again, regardless of what their LDL is, they should all be on at least moderate intensity statin in the absence of contraindications. And then the statin group 4, which has been the one that's been most controversial, using the risk calculator to define those at least 7.5% risk and consider for those at a 5% to 7.5%. So why controversial? 1, the risk calculator includes stroke risk, not just cardiac risk. 2, this captures a lot of people. Who's at risk? Well, you'd be surprised. 40, 50-year-olds, yeah, there are a lot of them that are at this sufficient level of risk. And guess what? When most of us get to about age 50, 55, the vast majority of us fall in this risk group. And once you get to about 60, it's pretty much everybody that falls in this risk group. And guess what? Those are exactly the individuals that derive huge benefits in the randomized clinical trials. So why is the guideline targeting them, meaning, millions more people will qualify for statins? Because these are the millions of people at risk for cardiovascular events that constitute the 1.5, 1.7 million heart attacks and strokes that are occurring each year. Okay, so most controversial area of the guidelines. Okay, so let's look a little bit. Does it make sense to target these individuals as we look at their absolute risk of events and absolute harm? If you say, let's throw everything bad a statin could even potentially do, whether it's due to the statin or due to placebo, and you can come up with a number needed to harm of 167. So no matter where you get on the risk group, down to ultra low risk and well below the threshold the guidelines pick, you're still very safely in the benefits outweighing the risks, at least according to here. Even when you say your relative risk reduction with your statins is only going to be 25 or 30%, even though we know we could get it as high as 50% relative risk reduction. So what did the guidelines say for people between 5 and 7.5%? They say, you know, if you're on the fence about them, there's some additional testing you could consider. Look at their family history, high sensitivity CRP. If you want to do coronary artery calcium, you can. Ankle Breakout Index. You could certainly treat anyone in this risk group, or you could try and further risk stratify them. So what about the risk calculator? So it builds on the Framingham risk score. It included more diverse patient populations. And again, it's defined those groups that are going to benefit from statins for primary prevention. You plug in your age, your sex, your race, your blood pressure, and your total cholesterol and HDL, and you can find out the 10-year risk and the lifetime risk of developing atherosclerotic vascular disease. And this has been converted to a nice free app that you can get on your iPhone, on your iPad, on your Google Android phone, or look it up on the web. And you can see how it's illustrated here nicely. And it prints out or displays for you your 5-year risk, or sorry, your 10-year risk and your lifetime risk. It shows you what's recommended in the guidelines regarding whether you fall in a statin risk group and what specific agents would be recommended in that regard. So you can see illustrated here, you plug in your systolic blood pressure, click the little buttons, no diabetes, no smoking, and this component, and there's the 10-year risk, calculated risk, and then you can also see illustrated nicely what would be your risk with optimal risk factor control. So the magnitude of benefit and reduction you could get with optimal risk factor control. In this individual, look at their lifetime risk going from 39% down to 8% with optimal control of risk factors. Okay, so here's the summary of the risk groups that we went through. So you can see kind of all of the basis for this. And the other things to kind of say, again, to reinforce, all adults should adhere to the healthy lifestyle, and obviously for primary prevention, starting statins, it obviously needs to be a discussion between patients to make sure, you know, this is something that they really want to buy into towards taking a medication each day. They understand the risks and the benefits, the small risk for diabetes, and engage in shared decision making. So that is really emphasized in the guidelines for primary prevention, but no more LDL goals for targeting for therapy. Now, importantly, while there are no LDL cholesterol goals that remain, that does not mean do not check lipid levels. It says explicitly in the guidelines to continue to check levels as a way of monitoring adherence to therapy in patients, and so that is absolutely critically important. So with regards to the general principles here, I think a couple things that this slide emphasizes what need to be discussed before starting a statin. So assessing the patient's risk, review the benefits from a heart-healthy lifestyle, review the potential benefits from statins, the potential for adverse effects, and patient preference, and then initiate treatment if appropriately. Now, the guidelines also say there are some circumstances where non-statin therapy may be considered, and you're going to hear more details about that in the next talk. For monitoring and follow-up, again, the emphasis, measure lipids regularly, so at 4 to 12-month intervals once patients are in therapy to monitor adherence. Some people have said, I can just ask patients if they're taking the meds, do I really need to check the lipid parameters? But at least the guidelines said so. And from a safety standpoint, there's really no actual labs that need to be monitored in patients unless symptoms develop. If they do, you can check things like CK if you're suspicious about onset of diabetes, fasting blood sugar, and hemoglobin A1C. Obviously, because muscle symptoms can be an issue, you want to talk to patients about what symptoms they had before you start them on therapy. Why? So when they're complaining the same thing afterwards, you can remind them you had the exact same symptoms beforehand. And most patients, you'll find that re-challenging them with statins, they can actually find a statin that they can tolerate pretty well. So there are some misconceptions about the guidelines that are shown here. So this idea that you must treat a patient with statins, no, you need to have a discussion with the patient. Shared decision making, no longer a role for rechecking lipids, no, there still is. No role for non-statin therapy, no, there remains a role for add-on therapy at provider discretion, recognizing our evidence is behind intensive statin therapy, and that the new risk estimator completely abandons Framingham. No, it doesn't. It builds on Framingham with additional risk cohorts. So there is a strong evidence base behind these guidelines. If they were implemented, that the Million Heart Campaign could be more like the 5 Million Heart Campaign, because we would be preventing so many more events. But obviously, effective implementation is a huge challenge, which is why we are all here. So there was much made out of this document that was published in the New England Journal of Vote. Look at the new guidelines. There are going to be so many more individuals that qualify for statin treatment. And the answer, is that a bad thing? Absolutely not. That would be a great thing, because these are the individuals having events. To put it in economic terms, existing use of statins saved our country $1 trillion, produced $1 trillion in net new economic value. If we had been even better implementing our statins, it would have been another $2 trillion that could have been achieved and can be achieved going forward. So with MI and stroke being leading healthcare expenditures, preventing them would be a phenomenal payoff. And then here is a study just putting into perspective of saying, okay, when does somebody get to at least moderate risk for heart disease, and look at the ages. And this matches very nicely with the risk calculator. So we need to recognize that and be more aggressively treating this patient population. The benefits from just the statin use we've already had. This is data looking from 2002 to 2007. Look at the reduction in MI hospitalizations, unstable angina, CAD, heart failure by applying some of our evidence-based therapies incompletely. We could have tremendous impact beyond this if all of the things part of Right Care initiative, a part of Million Hearts, as part of our evidence and guidelines are applied into practice. And as this slide emphasizes, look at the tremendous low cost of these therapies, even in combination for our patients, so they are affordable to almost everyone. So in conclusion, use of statin therapy is overwhelmingly supported by clinical trial evidence. Benefits direct proportion to LDL lowering. We can achieve very large risk reductions. The guidelines give us the basis and formation to identify those appropriate patients to treat, and we need our systems to optimize care delivery. Thanks for your attention.